Eptinezumab is known to be a preventive treatment for migraine. It's another CGRP monoclonal antibody, but what makes it different is it's an intravenous infusion. So it's a medication you usually are given through an IV, a little bit more invasive than these subcutaneous injections. What makes it unique in the intravenous form is its molecular design and the fact that because it's intravenous, its bioavailability is within 30 minutes. So it started to bring up this question to many of us clinicians. If your bioavailability is in 30 minutes and you're a preventive treatment, isn't it possible that you can actually start to feel better within that first hour? So what if a patient came into the emergency room during a migraine attack, which we know is not an uncommon thing? And what we also know about patients who go to the emergency room is that these are the patients that often use the emergency room as their primary care option, that they go to the emergency room, they don't end up linking in to see a primary care provider for migraine, they don't end up seeing a headache clinician, they don't end up in follow-up care. So they're kind of lost to treatment, they come in for these attacks, they don't get preventive started. What if that patient came in and was able to get a preventive that stopped the migraine attack within an hour, but had a type of sustained relief for 3 months and really allowed them time to establish care with a primary care provider or a neurologist to really evaluate their situation and then get them started on appropriate care? Couldn't we really change the way we're looking at migraine and treating migraine in the United States? This is some of the theory in the background, the conversations behind the scenes that were happening when the RELIEF trial was designed, which was a study looking at eptinezumab given during a migraine attack to see, would it actually resolve that migraine attack and how long before the next migraine attack would occur? Now, understand, eptinezumab is not an acute treatment. You cannot give it to a patient every time they have an acute attack. You can't use it every single day. You can't use it multiple times a month. It's FDA approved as a preventive to be used every 12 weeks. So it's not really an acute treatment trial, but we were using the same measures as an acute treatment trial. So this is a little bit confusing and a little bit hard to get your head around, but essentially, we use the same markers as an acute treatment trial with the primary endpoint of pain freedom in 2 hours and relief of and freedom from most bothersome symptom within 2 hours. So we were saying, are you pain-free and are you free from your most bothersome associated symptom during a migraine attack? And then we also were going to, and these aren't published results, they're going to look at how long before a patient had their next migraine attack after a single infusion. Of course, the patient has to come in during a migraine attack, so that's a challenge in itself because they have to come into an infusion center during a migraine. What if that migraine's in the middle of the night? Is there going to be an infusion center that's open? So this study was looking at patients who had a migraine attack and received their infusion within 6 hours of an attack itself, and then looked at how long before they had pain freedom, and during that time period compared to placebo, how did a patient do, and how did they do about taking rescue medication, and compared to not taking rescue medication, what portion of patients were symptom-free. So the abstract that I presented was looking not so much at the primary endpoints, which we do know that patients achieved pain freedom above placebo with eptinezumab at 2 hours. Actually, in fact, was statistically significant at 1 hour. A small portion of patients, almost 10% of patients, had a statistical significant pain freedom rate at 1 hour with eptinezumab compared to placebo. But we were looking at in this abstract, what about that most bothersome symptom? And then what if we separate those most bothersome symptoms out, knowing that in general for migraine, photophobia is the most common, most bothersome symptom. But what about phonophobia and nausea? What about these symptoms as well? How soon could we start seeing results? And did this sustain results over the 48-hour time period that patients were evaluated in this trial? And we saw that for individual symptoms of photophobia, phonophobia, and nausea, patients had improvement of these symptoms compared to placebo over that time period of 48 hours. That for photophobia and phonophobia, that that they achieved freedom from these symptoms within the first hour compared to placebo when treated with eptinezumab. And for nausea, they actually achieved statistical significance compared to placebo at 30 minutes, lost significance at an hour, and then gained it back at an hour and a half. So there's a little bit of fluctuation. We know historically in migraine, nausea is one of these more difficult symptoms to treat, that nausea tends to come with the more significant attacks. But it is interesting that it got better, got a little worse, and then got better again. It's hard to say if this is just a statistical variation or it has to do with the disease process itself. But overall, very good results. And again, achieved the fact that before 2 hours, patients were already having statistical improvement when treated with eptinezumab. So this is really exciting results. And it's a very interesting idea going back to you can start prevention during a migraine attack, get better within an hour to 2 hours, and potentially have a sustained response for a period of time. So it really is, I think, in the future going to change the way we can think about treating migraine. Very exciting.